Succes veterinær Praksis, podcast nummer 84. Dagens podcast er noget helt særligt, men først hej og velkommen til. Jeg hedder Søren Pejstrup, jeg er dyrlæge, og det er mig, der har startet projektet Succes veterinær Praksis. Det er et projekt, der består af den her podcast, du lytter til nu, nogle online kurser og så et e-mail nyhedsbrev med fokus på fagligt relevant indhold, protokoller, tips og tricks til det at være dyrlæge og for særligt interesserede veterinære sygeplejersker. Og til dagens podcast, der følger der et PDF-ark med et overblik over det, vi snakker om i dag, plus lidt om udredning af GI-patienter. Jeg har snakket om det i nogle af de andre podcast-episoder, hvor vi snakker også om GI-patienter. Og det er det samme ark, jeg nævner her. Og grunden til, at jeg nævner det i forbindelse med nyhedsbrevet, er selvfølgelig fordi, at vi bytter for din e-mailadresse, så får du den her PDF i bytte. Og jeg håber meget, at du har lyst til at være med på nyhedsbrevet, og det er jo selvfølgelig til dels lidt for at overtale dig til at prøve det af, hvis ikke du allerede er med. Men jeg håber seriøst, at du får noget reel viden og nogle gode, relevante protokoller ud af at være med på nyhedsbrevet. Hvis du kun er interesseret i den her PDF, så er det selvfølgelig også helt okay. Så kan du bare afmelde dig sekundet efter du har modtaget PDF-arket. Men jeg håber selvfølgelig, som sagt, meget, at du bliver hængende. Dagens podcast er særlig, fordi at jeg har været helt utrolig heldig at få fingrene i specialist Justine Lee. Hun er utrolig eftertragtet, og hun er en meget travl foredragsholder, så hun er svær at få fat i. Og jeg var så heldig at fange hende efter en af hendes forelæsninger på en konference i Lissabon. Vi sidder for foyeren og deler en kande isvand, så det er derfor, du kan høre lidt støj og lidt lounge-musik i baggrunden. Og hun var meget venlig til at stille op til at snakke om et af de emner, hun også har brugt en del tid over på sin egen platform, VETgirl on the Run. Hvis ikke du kender den hjemmeside, så vil jeg helt klart anbefale dig at tjekke shownoterne ud, hvor der er links til både hendes hjemmeside, til hendes online kurser og til hendes podcast. Fordi sådan en har hun nemlig også. Det er links og noter, som sædvanligt i shownoterne til det her afsnit på SIVP.dk/84. Og hvis du vil finde hendes hjemmeside direkte, så skal du bare søge efter VETgirl on the Run. Så finder du den. Hun er ret god til det her med søgemaskineoptimering, så jeg garanterer for, at hun ligger i toppen. Og jer, der allerede er medlemmer, I ved, at jeg fra tid til anden deler artikler fra hendes hjemmeside, sådan i vores interne kommunikation, og det gør jeg netop fordi, at det har et utroligt højt fagligt niveau, og hun er også uddannet specialist. Jeg kan klart anbefale at tage et smut forbi hendes hjemmeside, for der er virkelig meget godt at lære, og Justine er en rigtig dygtig forelæser, og det får du formentlig også fornemmelsen af i dagens interview. Hun går direkte til de vigtige informationer, og så over til interviewet med Justine. So, Justine, thank you very much for taking the time to talk to me.
Of course, happy to do so.
You have a lot of projects, and you're very, very well known in our industry. But can you please give us a Cliff Note version, maybe?
Sure.
What are you up to?
Sure. So I'm an emergency critical care veterinary specialist, and I'm also a toxicologist. And I did my veterinary training in the United States at Cornell for veterinary school. Went on to do my internship at Angel, which is part of the MSPCA in Boston, and then went on to do my emergency critical care residency at University of Pennsylvania. And I've practiced everywhere. I practiced in academia at University of Minnesota for 5 years. Then I went into industry and headed an animal poison control for 5 years. And 5 years ago, branched out to start VETgirl, which is an online continuing education platform. And I still practice in the Twin Cities. I practice 2 days a week at a veterinary specialty practice in Minnesota.
Yep. And you had an article on parvovirus and what you call the Colorado protocol for parvovirus.
Yeah.
And I'd like to talk to you about that. And obviously, there will be links in the show notes as well. But if we go through parvovirus, I think most would wonder how to manage these cases. But
sure.
Maybe we should just touch on some of the clinical signs before we do that.
Absolutely. So, it's still frustrating in this day and age that we're seeing parvovirus to begin with, because the vaccine is 99% effective. And so parvovirus was first discovered in the 60s and 70s and decimated puppies and litters and kennels. And unfortunately, I tell people, or pet owners, it's like dying of cholera nowadays. It's rare, but they die of severe dehydration. And so clinically what we see is it's usually an undervaccinated or unvaccinated group of dogs. So they're either puppies where they didn't get any maternal antibody or the mother wasn't vaccinated. They were stressed, they were shipped. So unfortunately, we still see quite a bit of parvovirus, even in the United States. And the biggest clinical signs we see are typically lethargy or malaise, not wanting to eat, listlessness or not moving, followed by drooling from nausea, vomiting, diarrhea that progresses to a bloody diarrhea. And unfortunately, the way that these parvovirus dogs, or usually puppies, die is typically by severe dehydration that progresses to hypovolemia and, I would say, secondary hypoglycemia. Dogs can also get secondary complications like aspiration pneumonia. They can get sepsis from bacterial translocation on top of their leukopenia that they develop. So it is a frustrating disease because it can be very costly to treat. But again, so important that we as veterinarians educate our pet owners. It's totally preventable, and this is why it's so important that we appropriately communicate with our pet owners. One vaccine is not protective. And a lot of people think, oh, my dog got one vaccine, he's safe. No, he needs 3 to 4 vaccines every couple of weeks, starting from 5 to 6 weeks of age until 14 to 20 weeks of age if he's a high-risk breed. So classically, we see parvovirus in puppies less than 6 months of age. Certain breeds are definitely overrepresented, so Rottweilers, Pit Bulls, Dobermans, German Shepherds, Labradors, and oftentimes it's male intact dogs that are overrepresented. So between the weeks of 6 to 20 weeks of age is our most critical period where we worry about these puppies getting sick from this infectious disease.
Yeah, and we have a SNAP test, and with this diagnosis, it's pretty well. It's straightforward.
Yeah.
But what else is important in the diagnostic workup?
Sure. So one of the biggest things that we do to work up some of our parvovirus cases is most of us do have an ELISA test. So it's a parvovirus fecal antigen test, but I also look at that in terms of history, clinical signs, age of the puppy, and a blood smear or a complete blood count. Because what we worry about is sometimes we will see a false negative for parvovirus, and that can happen if the patient hasn't had a chance to mount an immune response, if the patient has such severe voluminous diarrhea that there's a dilutional effect. So just be aware there are false negatives and false positives from these. Even something as little as using lubrication on the Q-tip or the swab can affect the test. So it can make a false negative, or even intermittent shedding. So it is relatively easy to diagnose. I always say, when in doubt, do a blood smear, look for the presence of leukopenia. And if they're leukopenic, even if they have a negative ELISA, and they fit with the clinical picture of parvo, they go into isolation regardless.
Okay, and so we have these small pups in the clinic, and we are pretty confident that they have parvovirus. Mm-hmm. So how do we start to manage these? How do we start to treat it?
Yeah, great question. I would say the mainstay therapy is hydration. What they die from is dehydration and secondary complications. So I want to be pretty aggressive, and the biggest mistake I see veterinarians making with the treatment of parvovirus is underutilizing IV fluids. And people will say, oh, I have them on 3 times maintenance, so I'm doing a good job. Well, in actuality, you're not, because the maintenance for a puppy is much higher than an adult. We're all taught in veterinary school that the maintenance for a puppy is 50 to 60 mils per kg per day. Well, for a very young neonate, their maintenance is 120 mils per kg per day. For a pediatric patient that's a little bit older, it's 60 to 80, up to 100 mils per kg per day. So you want to make sure you're calculating your maintenance appropriately. And again, if they're hypovolemic, their blood pressure is low, they're tachycardic, they have poor indicators of perfusion, they are going to need some shock fluids on top of aggressive fluid therapy for maintenance. And don't forget, they have very large amounts of ongoing losses. They have such severe vomiting, such severe diarrhea, so we have to add in that amount that they're losing into their IV fluids. The second mainstay therapy is gastrointestinal support, so using a really strong anti-vomiting medication. In the United States, I use meropitant, which is a very potent antiemetic, and I oftentimes will use prokinetic if the dog sounds like he's got ileus. When I auscult their gut, they have no bowel contractions. So really important that you use a potent antiemetic. I actually don't believe in feeding them initially because we need to make sure we have their vomiting under control first because we don't want them to aspirate. So
I was taught to this early feeding, but it can be, in reality, when you're in the clinic, it's a pain to get food into these.
Yeah.
They're vomiting and they're struggling and they're circling around. It's nice to hear you say that.
Yeah, and I would say, a lot of the criticalists out there say you should implement early nutrition, but I always tell people when you're hungover from drinking, you don't want someone shoving a burrito into your mouth. So you want to make sure that nausea is controlled. So for me, it's always perfusing and making sure that patient has normal parameters before you even think of feeding them. Is their temperature normal? Is their blood pressure normal? Do they have gut sounds? A day or two later, then you can feed them. So really important to hydrate them first, get that vomiting under control. And then the third thing is really antibiotic therapy. Remember, it's a viral infection, but if they're leukopenic, less than 2,000 white blood cells, they can get septic. So I usually will put them on a gram-positive antibiotic like ampicillin. If they become leukopenic, less than 2,000 white blood cells, I'll add on something more potent, like a gram-negative. So something like enrofloxacin or ampicillin sulbactam, something that's going to be broad spectrum for gram-positive and gram-negative. So to me, those are the three mainstay therapies: IV fluids, gastrointestinal support, and antimicrobial therapy, and really symptomatic supportive care. I should step back and say for IV fluids, you should put them on dextrose. And obviously, if they're hypoglycemic, you want to bolus them IV dextrose. But most clinics aren't open 24 hours a day. And I would hate for a puppy to be found dead in the cage from hypoglycemia. So I would rather the patient be on 5% dextrose in the IV fluids or 2.5% dextrose, especially if nobody's there at night.
Yeah. And what other kinds of fluids do you use? Do you use colloids or you'd use a mix or?
Yeah, that's a great question. I would say most of them need just a balanced crystalloid. So I don't care what you use, from Hartmann's to saline to lactated ringers. It should be a balanced fluid. And it should have, 2.5 to 5% dextrose. It should probably have some potassium supplementation in there too. And so my general rule is they usually need at least 4 to 5 times maintenance initially. So monitor them really carefully. If my patient is persistently hypotensive, I give it a crystalloid bolus. I recheck a blood pressure. I give it another crystalloid bolus. It's still dehydrated. Then I will sometimes reach for a colloid. Now, I used to use colloids a ton, by the gallons or the liters, and I've never had a problem. But recent literature in both human and veterinary medicine has found that with really large colloids, really large molecules, it can actually rarely cause acute kidney injury. So I'm a little bit more conservative with reaching for colloids, especially if they are azotemic or they have a pre-renal dehydration or azotemia, or they have gotten into a nephrotoxicant like grapes or raisins. So that said, remember that puppies are normally hypoproteinemic, and that's because they have a low globulin from low immune stimulation. So a total protein of 5 or 50, depending on the units, that's normal for a puppy. Once we hemodilute them, their total protein may drop to 3.5 or 35, and that's okay. If they're still hypotensive, if they're getting edematous, then I will reach for a colloid.
And how about the plasma or blood transfusion?
Great question. So Soren, thank you for asking that. That's actually one of my pet peeves. I don't think most of these guys need plasma. And there's a lot of literature out there that has shown recently that fresh frozen plasma, in an attempt to increase the antibodies to that patient and provide them some, parvovirus immune stimulation, does not work. It's been debunked. It doesn't work. It doesn't help. Now, don't get me wrong. If your patient is in disseminated intravascular coagulation and is coagulopathic, then absolutely, you should use plasma. But if their coag is normal, you do not need to use plasma. And in fact, the reason why I don't is because plasma is actually pro-inflammatory, and now you've triggered that patient for the next 10, 15 years to have a reaction to a transfusion. Remember, dogs in life get one free transfusion, and you may have just taken that by giving it to a parvovirus patient when they don't necessarily need it. So only if coagulopathic. Now, remember, most parvovirus patients, they do get anemic, and it's because they're losing a lot of blood through their gut. My, quote, transfusion trigger, the packed cell volume where I decide to transfuse them, is honestly around 20%. So if their PCV is 20%, I might transfuse them. But more importantly, I keep in mind that the bone marrow of a puppy, once they're feeling better, it's going to regenerate red blood cells. So unless they're failing to respond to IV crystalloids, honestly, they rarely need a whole blood transfusion. In the 20 years of practicing and having treated hundreds of parvovirus patients, I probably have transfused 1 or 2.
Okay. And what about pain medication? Are they?
Great question.
Do you use any of that? Are they in pain?
Yeah, that's a great question. I would say I honestly am a little bit different than other criticalists in that I don't usually like to give pain medication. Why? Because first of all, they already have GI signs, so I'm not going to reach for an NSAID, a non-steroidal. And when I'm sick with the gastrointestinal flu, nobody gives me an opioid, right? And remember, opioids predispose them to vomiting. I'm worried they're going to aspirate, and it causes ileus. So I would say I do not use pure mu opioids. I don't think they're warranted. If the dog's abdomen is painful, if they're really hypermodal, sometimes I will consider low-dose buprenorphine, but I don't think they need a pure mu opioid. So in general, I really base this on human medicine. When you have the gastrointestinal flu, you don't get opioids. You get hydration, and hydration is probably the most important thing.
Okay. So I sort of interrupted you there. Is there anything else we need to consider here?
In terms of treatment, I think the biggest thing is not giving up on these puppies, because studies have recently shown the prognosis is 80 to 90%. And so even if the owner has financial limitations, I would still be pretty aggressive about treating these patients, whether or not it's in the hospital or outpatient.
So, but what is it that caused them us to lose them? The last 20% maybe.
Yeah.
So what do we do wrong in the cases where we lose them?
Sure, that's a great question. So the textbooks say it's because of bacterial translocation. The textbooks say it's because of hypercoagulability from DIC. But in real life, in my clinical experience, it's not from that. It's from hypoglycemia that wasn't treated, or aspiration pneumonia from aspirating the food that you're force feeding into them. So to me, that's one of the reasons why I'm pretty adamant that they should be on dextrose supplementation, or you should be monitoring their blood glucose several times a day. And that's the second reason why I'm one of the few criticalists that I don't jump to feeding them right away, because I want to make sure they can handle the food and they're not going to get the life-threatening complication of aspiration pneumonia.
How about feeding tubes?
So feeding tubes are a great option. I would say that the specialty emergency clinic that I work at oftentimes jumps to putting in feeding tubes pretty quickly into these puppies. But I also think that you have to be a little bit careful. I've seen some puppies die from aspirating enteral liquid diets. What we use in the United States is a brand called Clinicare, and I've seen Clinicare come out of their nostrils because they have severe regurgitation. So to me, nutrition's important, but it's really the fourth or fifth thing on my list.
Yeah, I'm a bit hesitant because you also need to sedate them to put it in.
Yes.
And some of the puppies are not sedatable.
Yeah.
You're not
Yes.
in the start, in the beginning anyway. So.
Yeah, and it's interesting because then they always have to wear the Elizabethan collar.
Yeah.
So they're a little bit miserable from that. I oftentimes find that people feed the wrong things to puppies. So, the dog's been in the hospital for 4 days. It won't eat. Everyone's offering, chicken, baby food. Try dry dog food. A lot of people forget. And then, I'll go over, offer them dry dog food, which is what they're used to. They'll start eating. They also get food aversion. They're so nauseous. They don't want to be force-fed. And so if they don't eat willingly on their own, sometimes I'll remove that food after 5 minutes so they don't get food aversion.
Yeah. And one of the things I've really liked about your article about the Colorado protocol is some of these patients can be a pain, just to be honest.
Yes.
So you put an IV catheter in and you're very satisfied with the placement and you turn your back to it and then you chews it off or it turns around 100 times in the cage and then you circle to all four legs and you have this critical care food everywhere and it's just horrible. So please tell us about the...
Sure. So there is something that is often, quote, termed the CSU or the Colorado Protocol. And this is based off a study by Venn et al. That was published in the Journal of Veterinary Emergency Critical Care in 2017. And it's called the Evaluation of an Outpatient Protocol in the Treatment of Canine Parvoviral Enteritis. And in the study, they prospectively looked at 20 dogs that were treated on an inpatient group, 20 dogs that were treated on a, quote, modified outpatient group. Now, it's important to note that all these dogs received IV fluid resuscitation first. They all had IV catheters in. They were all bolused fluids. They were all bolused IV dextrose if they were hypoglycemic. And the inpatient group was treated with IV fluids, cefoxitin, the antibiotic, meropitant, the antiemetic, and they received IV dextrose and potassium supplementation. They were then offered food once they were no longer vomiting, so Hill's AD. And if they didn't eat it willingly, they would syringe feed 1 ml per kg orally, approximately every 6 hours. The outpatient group, after receiving IV fluid resuscitation and stabilization, then received outpatient therapy. They were still hospitalized for monitoring purposes in the study, but they received 30 mils per kg of subcutaneous fluids every 6 hours. The second part of outpatient therapy was the group would receive Convenia, a long-acting third-generation cephalosporin, at 8 mg per kg sub-Q once, and that normally lasts about 1 week in dogs. They also received meropitant sub-Q. They received oral dextrose and potassium supplementation orally, and they were also syringe fed. And interestingly enough, the survival in the inpatient group was 90%. In the outpatient group, it was 80%, which is still pretty darn good. So what they found was that the average duration of hospitalization in the in-hospital group was 4.6 days. And that's what I find. They usually are in the hospital for 4 to 5 days. The outpatient group, even though it was, quote, hospitalized to mimic therapy at home, they received care for 3.8 days. So still, they need 4 to 5 days of care. What they found in the Venner study was that 50% of dogs treated in the outpatient group needed dextrose and 60% needed potassium. They also found that of the dogs that didn't survive, so 1 out of every 5 dogs, they were more likely to die or be non-survivors if they were thin or small, so less than 4 kgs, and young, less than 4 months. So that study was interesting because it gave us some options for pet owners who had financial limitations. Now, the gold standard is still they should be hospitalized on IV fluids and in-hospital therapy, but it was rewarding and refreshing to see that some of these are savable on an outpatient study. Now, similarly, there was another study that came out that same exact year, and this was a study that was done in Texas. And this was a study by Sarpong et al. Called Evaluation of Mortality Rate and Predictors of Outcome in Dogs Receiving Outpatient Treatment for Parvoviral Enteritis. And this study was actually very similar. They found a slightly higher mortality at 25%. So you still have to quote to your owners, 1 out of every 4 or 5 dogs is still going to die. And to me, it's a horrible way to die at home. So if they don't respond, you have to offer humane euthanasia. In this study, by Sarpong et al., they did not find any difference between age and weight like the previous study. And what they found was that dogs that were fed a caloric supplement every few hours actually had a slightly lower mortality rate. Instead of being 25%, it was 19%. And these patients were also treated with subcutaneous fluids, antiemetics, and antibiotic therapy. So I think the key thing from these 2 studies, whether or not you call it, the Colorado protocol or this Texas protocol, is all canine parvovirus cases should ideally be hospitalized because that's the gold standard. But be able to work with your pet owner as best you can to be able to save these puppies because the prognosis is fair to good with supportive care if you have a dedicated pet owner. If you don't have a dedicated pet owner who's willing to do subcutaneous fluids, 3 to 4 times a day, they're not willing to come to your clinic at least once a day for recheck for 4 days, then it is more humane to consider euthanasia. But these 2 studies basically proved what shelter veterinarians have been doing across the world for, several decades, is that we can treat a lot of these guys on an outpatient basis. So important that veterinary professionals know we need to educate our pet owners more about preventative care, appropriate vaccination, and more importantly, that we work with our pet owners to help treat these guys. They're savable.
But what I also get out of it is that you cannot just send them home, and you need to stabilize them first.
Absolutely.
So of course, it's nice to have an alternative to owners that don't want to have the puppies in there for 6 days. But, but you still have to use a lot of time. You have to use some energy both on the patient and to explain to the owner.
Absolutely. And so that's why I say if you're seeing a lot of parvovirus, make sure you have a easy client handout where they can check off when they gave the fluids, how to give the fluids. You can direct them to a website or a YouTube video on how to give fluids subcutaneously. That you have them sign a contract that they're committed to coming once a day to your clinic for 4 days, and you charge for that visit, right? So they have to be responsible for that, for financially working with you. So again, really important that we educate our pet owners on that.
Yeah. Just a side note, if you have been working with a parvo puppy for a couple of days and you're completely tired and worn out veterinarian and you charge the owner, and sometimes they will come back and say that's way too much money for hospitalization. So if you give the puppy home and all the work and they have to do it, they can see for themselves.
Yes, absolutely.
How big work, how
yes,
much work it goes
they have to be
into.
fully committed. And so again, if owners have financial limitations, my ideal is you hospitalize them, you put a catheter in, you bolus them fluids, you be very aggressive hydrating them. So 4 to 5 times maintenance. You start that antiemetic therapy, you start them on either a long-acting or short-acting antibiotic. And then once you have their vomiting under control, then you implement nutritional support. If your clinic isn't open 24 hours a day, which most vets aren't, then you send them home at night. You give them some sub-Q fluids, you teach the owners how to do it, and then they come back the next day and you hospitalize them during the day and they go home at night. So really important that you work with owners, but again, these guys are savable.
Yeah. So thank you very much.
Sure.
I'd like to take just a couple of seconds to talk about VETgirl.
Sure, absolutely.
And you have a podcast as well.
Yes. Yeah, thank you. So I started VETgirl about 5 years ago, and so it's basically one of the first companies to start online veterinary continuing education or continuing professional development or CPD. And so it's $199 US a year, but that gives you access to over 40 hours of new CPD a year. And you get access to all our other years of libraries. Plus, we teach with videos. So if you're not sure how to unblock a cat or put an IV catheter in or do a thoracocentesis, 90% of our videos are locked to just our subscribers. We have a small percentage on YouTube. And we also have free podcasts. So our podcast, you can just Google under Apple Podcasts or Stitcher or whatever you're using.
So this is a podcast, so people listening to this would obviously...
sure. They're usually pretty savvy.
Yeah. But in iTunes and everywhere you get your
absolutely.
podcast.
So wherever you get your podcasts, they're for veterinary professionals. They're not for pet owners. And we release a new podcast every Monday, a new blog every Friday. And so it's been really fun. Our podcast we've been doing for 5 years, and we're excited. They've been downloaded over 1.7 million times in 170 countries. So it's a really fun way of being able to help educate the world and improve their quality of care with just podcasts.
Yeah. And you have something new coming out this fall, right? Are you allowed to talk about it?
Of course. Do you mean our veterinary conference?
Yeah, that too.
Okay.
You have something you call VETgirl U.
Yeah.
And the conference is a new thing also?
Yes. So VETgirl U is actually our veterinary conference. We're hosting our first live conference in person in August. So August 17th to 19th. And it's going to be held in Minneapolis, which is in the center of the United States. And I'm really excited. We always have been committed to providing continuing education that is clinically relevant and practical, but we've always been behind a screen. And so this is the first time we're offering live CE. It's actually sold out. We have 500 people who are coming from across the world to attend. So thank you. We're really excited. This is not a conference we're going to do every year. It's not even a conference we're going to do every couple of years. Our goal is always online CE, but it was just a great opportunity for us to connect with our fans live in person. So super excited for that, and we'll see how it turns out.
Thank you for taking the time to talk to me.
No problem. Thank you so much for having me on, Soren.
Husk 2 ting. Husk at tjekke Justines hjemmeside ud, VETgirl on the Run, og husk at få din pdf til de her GI-patienter. Den kan du få over på hjemmesiden, sammen med links til både Justines hjemmeside og til hendes podcast på SIVP.dk/84. SIVP.dk/84. Vi er ikke helt færdige med at snakke GI-patienter, men det kommer der mere om på næste søndag. Vi høres ved.